Sahil Sangvi. Last one.
This one. This one.
Yeah. What do you say? Okay. Good afternoon. Today I'll be talking to you about the spinopelvic relationship and its implications in total hip replacement. So we all know about Levenick's safe zone, where he said that the acetabular inclination should be averaging 40 degrees and anteversion should average 15 degrees. But I don't know how many of you all have actually read this paper word by word, and if you have, you will realize the inherent flaws in this paper. They studied 300 patients and they had 9 dislocations. But the startling fact here was that out of 291 patients, X-rays of 178 patients without dislocations were actually not evaluated at all. And that is why Matt Abdel and their group from the Mayo Clinic asked, what safe zone are we really talking about? Because the vast majority of dislocations are actually within the safe zone. And they studied about 10,000 patients with primary total hips, and they had a dislocation rate of 2%. But they found that 58% of these dislocations were actually within the safe zone. So as we know, dislocation is multifactorial, and this brings us to the hip-spine-pelvis relationship. Just a disclaimer that this is an extremely theoretical topic with all the angles, so I'll be covering only the practical point of total hip arthroplasty. The most important concept is the biological opening of the acetabulum. So when we go from the standing to the sitting position, it's not that the femur flexes 90 degrees. The femur only flexes 70 degrees, whereas there is a posterior pelvic tilt of 20 degrees. So if you see in this video, as the femur is flexing, the pelvis is tilting posteriorly by 20 degrees, and the lumbar spine goes from lordosis to a flat back or a kyphotic posture. And there is increase in the anteversion and inclination of the acetabulum, which is known as the biological opening. So if you see the image on top, in the standing position, the dark black component is the acetabular component, and in the standing position, it's facing relatively down. But as we go to the sitting position, as denoted by the red arrow, you can see how much the acetabular component is actually opening up over here. So there is an increase in the functional anteversion, and then it is but obvious that in patients with spinal fusion or limited spinopelvic mobility, there is an increased risk of stability and impingement. So the rotation of the pelvis in the sagittal plane can be assessed by 3 parameters. You have the anterior pelvic plane tilt, the spinopelvic tilt, or what I personally prefer is the sacral slope. So how do you measure this sacral slope? You draw one line parallel to the superior end plate of S1. A second line is the horizontal reference line, and the angle between these two lines is the sacral slope, which is the easiest to calculate and judge visually. So look at the image on the left. In the standing position, the sacral slope is about 40 degrees. But in the sitting position, the pelvis tilts posteriorly, so the sacral slope is now 20 degrees. So there is a change of 20 degrees from the standing to the sitting position, which implies 20 degrees of posterior pelvic rotation. You can also use the anterior pelvic plane tilt or the spinopelvic tilt. I won't go into the details of that. So here is my algorithm for evaluating patients with spinopelvic imbalance. The X-rays you should take are the AP pelvis X-ray in the supine and the standing position, and the lateral spinopelvic views in the sitting and the standing position. The first step is to identify the patient with a spinal deformity. So here you compare the supine AP and standing AP pelvis X-rays using various parameters. So if you see the image on the left, if you see an image like this, where the coccyx to pubic symphysis distance has increased and the obturator foramina here appear more like winking eyes, or they're obliterated. So this implies an inlet kind of view, and this may tell you that the patient has a hyperlordotic spine or a fixed flexion deformity in the hip. Whereas if you obtain an image which is similar to an outlet view, you can see here there is a significant overlap between the coccyx and the pubic symphysis, and the obturator foramina are more oblong. So this may tell you the patient has either a flat back or a kyphotic spine, or may have ankylosing spondylitis. You can evaluate for pelvic obliquity using the ASIS or the base of teardrops or the ischial tuberosity, and this will give you an idea whether the patient has a scoliotic spine or if there is an adduction or abduction contracture. Then you evaluate the standing lateral spinopelvic radiograph for anterior or posterior pelvic tilt using these angles. In the standing lateral spinopelvic radiograph, you evaluate the lumbar spine, whether the patient has had any lumbar spine surgery done, is there any listhesis, or is there a flat back or a kyphotic spine. Then you compare the standing and the sitting lateral images, and you look for the functional change. So as I mentioned, the sacral slope is the easiest to calculate for this parameter. And then you have the classification based on the difference in the angle from the standing to the sitting position. So if there is a tilt of less than 20 degrees, it is called as a stiff spine. If it is a 20 to 35 degree tilt, it's a normal spine. But if there is more than 35 degrees tilt, then you have a hypermobile spine. So if you have a hypermobile spine, there are no real adverse consequences because this patient is at less risk for impingement. Whereas if you have a stiff spine, that is, there is a difference of less than 20 degrees between the standing and the sitting position, it implies some spinal pathology like a degenerative disc disease or a spondylosis or ankylosing spondylitis. Then you need to plan for adjusting your acetabular component position. So if you have a patient with posterior pelvic tilt, this patient has an increase in the functional anteversion, and which is why you must give less anteversion to this patient to prevent anterior dislocation. If you have an anterior pelvic tilt when standing, the patient may either have a hip fixed flexion deformity, which you can elucidate with your Thomas test, and if it is positive, you can go ahead with a routine cup position. But if the patient has a spinal deformity, then the stiff spine will have less posterior pelvic tilt while sitting. So then you have to increase the anteversion to accommodate the femoral flexion while sitting. So if you have a hypermobile spine, give less inclination and less version, but if you have a stiff spine, you should give more inclination and more anteversion. These are the values that have been proposed for the ideal cup position, and this is where the value of robotics comes into play. And the Mako 4.0 even allows you spinopelvic impingement modeling, which is a great tool for these patients. And now we have the death of the Levenick safe zone because all these patients with different spinal deformities cannot have standard acetabular component positioning. Thus, to conclude, if you have a normal or hypermobile variant, they are at no risk for impingement. But if you have a kyphotic spine or a fused spine, you need a higher inclination and version, and dual mobility is again a great tool for these patients. Thus, to conclude, patients with spinopelvic imbalance are at risk for impingement and dislocation. You can at least start with this algorithm for fused spine cases or those cases where you know there is a lumbar spine pathology. Dual mobility is a safer option, and navigation or robotics will help you with precise placement of your cup. Thank you, Dr. Ashish and team AMC for this opportunity.
Right. Thank you for your talk, Dr. Sahil. Excellent talk. Ashish, can you just give a mentor to Dr. Sahil? And
so this time today, probably we have a bottle of whiskey inside.
so any quick question? Right. Okay. Okay. So since there are no questions, we'll go to the next talk by Dr. B.D. Chatterjee, sir, and he is on